Okay, so we are going to read about cholecystitis and cholelithiasis from Nelson's volume number 2, page number 2502. We are going to start from diseases of gallbladder. The incidence of gallbladder disease, particularly cholelithiasis and biliary dyskinesia, has been increasing in the children and has been associated with rise in the number of cholecystectomies. Anomalies. The gallbladder is congenitally absent in approximately 0.1%. Absent in about 0.1% of the population. Hypoplasia or the absence of gallbladder can be associated with extrahepatic biliary atresia or cystic fibrosis, right? So if there is hypoplasia or absence of gallbladder, it is associated with there is extrahepatic biliary atresia or cystic fibrosis. Fine, this is something that we should know. Moving ahead, duplication of the gallbladder occurs rarely. Gallbladder ectopia may occur with a transverse, intrahepatic, left-sided or retroplaced location. Multi-septate gallbladder characterized by the presence of multiple septa dividing the gallbladder lumen is another rare congenital anomaly of the gallbladder. So here we talked about the congenital anomalies present in the gallbladder. It can be hypoplasia or absence of the gallbladder, which was associated with extrahepatic biliary atresia and cystic fibrosis. There can be duplication of the gallbladder. There can be duplication. There can be ectopia, or there can be multiseptate gallbladder. Fine. And moving ahead to acute hydrops. This table lists the condition associated with the hydrops of the gallbladder. Acute non-calculous, non-inflammatory distension of the gallbladder can occur in infants and children. So there can be distension of gallbladder in infants and children, which is non-calculous, not due to any stone, and non-inflammatory also. It is defined by the absence of calculi, bacterial infection, or congenital anomalies of the biliary system. The disorder may complicate acute infections and Kawasaki disease, but the cause is not often identified. Hydrops of the gallbladder may also develop in patients receiving long-term parenteral nutrition. These are the conditions associated with the hydrops of the gallbladder. Moving ahead, presumably because gallbladder stasis during the period of enteral fasting. Hydrops is distinguished from acalculous cholecystitis by the absence of significant inflammatory process and is generally benign prognosis. So how is hydrops distinguished from acalculous cholecystitis? By absence of any inflammatory process and generally benign prognosis. Affected patient usually have right upper quadrant pain with a palpable mass. In gallbladder hydrops, there is a palpable mass. Fever, vomiting and jaundice may be present and are usually associated with systemic illness such as streptococcal infection, ultrasono. Fine. So what we saw was there can be fever, vomiting and jaundice may be present and they are associated with any streptococcal infection. USG shows a markedly distended echo-free gallbladder without dilation of the biliary tree. Fine. There is no dilation of the biliary tree. Acute hydrops is usually treated conservatively with a focus on supportive care and managing the intercurrent illness. Cholecystectomy and drainage are rarely needed. Fine. This drainage and cholecystectomy are rarely needed. Spontaneous resolution and return of the normal gallbladder function usually occur over a period of several weeks. If a laparotomy is required, a large edematous gallbladder is found to contain white, yellow or green bile. Fine. So if laparotomy is done and a large edematous gallbladder is taken out, and then we can see a white, yellow or green bile in that. Obstruction of the cystic duct by the mesenteric adenopathy is occasionally observed. So there can be obstruction of cystic duct occasionally due to mesenteric adenopathy. Fine. Cholecystectomy is required if the gallbladder is gangrenous. When is cholecystectomy required? If the gallbladder is gangrenous. Pathological examination of the gallbladder shows edema and mild inflammation. Cultures of the bile are usually sterile. So now starting from cholecystitis and cholelithiasis. Acute acalculous cholecystitis is uncommon in children. What is uncommon is any acute presentation of acalculous cholecystitis. Like there is inflammation of gallbladder not due to stones. This is uncommon in children and is usually caused by infection. Pathogens include streptococci, group A and B, gram-negative organism, particularly Salmonella and the Leptospira interrogans, and a number of viral infections like the hepatitis A, Epstein-Barr virus, and cytomegalovirus. Parasitic infestations with the Ascaris or Giardia lamblia may be found. Acalculous cholecystitis may be associated with abdominal trauma or burn injury or with a severe systemic illness such as leukemia, end-stage liver disease, and systemic vasculitis. Clinical features include right upper quadrant or epigastric pain. So patients with cholecystitis will have right upper quadrant or epigastric pain, nausea, vomiting, fever, and jaundice. Right upper quadrant guarding and tenderness are present. Ultrasound discloses an enlarged thick-walled gallbladder without calculi. So what will be seen on the ultrasound? There will be one second. On ultrasound, there will be enlarged thick-walled gallbladder without any calculi. Serum alkaline phosphatase activity and direct reacting bilirubin levels are elevated. There is increase in the ALP levels and direct reacting bilirubin levels are elevated, and there is leukocytosis. Patients may recover with the treatment of the systemic and the biliary infection. Because the gallbladder can become gangrenous, daily ultrasonography is useful in monitoring the gallbladder distension and wall thickness. Okay, so there is chance of gallbladder becoming gangrenous, so daily ultrasonography may be useful. Why? Because of for monitoring of gallbladder distension and wall thickness. Cholecystectomy is required in patients who fail to improve with the conservative management. Fine. Cholecystectomy is not required in everyone who fail to improve with the conservative management. Cholecystectomy drainage is an alternative approach in critically ill patient. Fine. Now starting with the cholelithiasis. Cholelithiasis is a relatively rare and otherwise healthy children, occurring more commonly in patients with the various predisposing disorders, which is again written in another table. Gallstones are rarely detected by ultrasonography in the fetus but generally remain asymptomatic and resolve spontaneously during the first year of life. In an ultrasonographic survey of 1,570 children ages between 6 to 19 years, the overall prevalence of gallstone disease was 0.13%, 0.27% female in female subjects. Older reports consistently found that more than 70% of the gallstones were pigment type. 15. Okay, so we have to remember this, that more than 70% of the gallstones were pigment type, 15 to 20% were cholesterol stones, and the remainder were composed of mixture of cholesterol, organic matrix, and calcium bilirubinate. Black pigment gallstones, composed mostly of the calcium bilirubinate and glycoprotein matrix, are frequent complication of the chronic hemolytic anemias. In chronic hemolytic anemias, what will be seen are the black pigment stones, which are composed of what? Mostly calcium bilirubinate and glycoprotein matrix. Fine. However, because of obesity, cholesterol gallstones now predominate in children, while the number of patients with the hemolytic anemia associated gallstones have remained stable. So what is present? We have to remember this, that the black pigment gallstones, composed mostly of calcium bilirubinate and glycoprotein matrix, are frequent complication of the chronic hemolytic anemias. Fine. Brown pigment stones form mostly in the infants as a result of biliary tract infection. Because of biliary tract infection in the infants, we can see brown pigment stones. Unconjugated bilirubin is the predominant component formed by the high beta-glucuronidase activity of the infected bile. So this brown pigment main content is unconjugated bilirubin. Cholesterol gallstones are composed purely of the cholesterol or contain more than 50% cholesterol along with the mucin glycoprotein matrix and calcium bilirubinate. Calcium carbonate stones have also been described in children. Fine. Patients with the hemolytic disease, including the sickle cell anemia, the thalassemia, and the red blood cell enzymopathies, and Wilson's disease, are at risk of black pigment cholelithiasis. Fine, this what we read, these gallstones, who are at risk of these gallstones: sickle cell anemia patients, thalassemia, red blood cell enzymopathies, and Wilson's disease also. In sickle cell disease, pigment gallstones can develop before age 4 years and have been reported in 17 to 33% of the patients 2 to 18 years of age. Genetic variation in the promoter of the uridine diphosphate glucuronide transferase and underlies the Gilbert syndrome is a relatively common chronic form of the unconjugated hyperbilirubinemia and is a risk factor for the pigment gallstone formation in the sickle cell disease. 1 second. Cirrhosis and chronic cholestasis also increase the risk of pigment gallstones. Fine, so cirrhosis and chronic cholestasis increases risk for what? Pigment gallstones. Okay. Sick premature infants may also have gallstones. Their treatment is often complicated by such factors as bowel resection, necrotizing enterocolitis. So, we saw that sick premature infants may also have gallstones, and their treatment can be complicated by factors like this: bowel resection, necrotizing enterocolitis, prolonged parenteral nutrition without enteral feeding, cholestasis, frequent blood transfusion, and use of diuretics. Cholelithiasis in premature infants is often asymptomatic and may resolve spontaneously. Brown pigment stones are found in infants with obstructive jaundice and infected intra and extrahepatic bile ducts. These stones are usually radiolucent, owing to lower content of the calcium phosphate and carbonate and a higher amount of cholesterol than the black pigment stones. MDR3 deficiency caused by the ABCB4 pathologic gene variant is a cholesteric syndrome related to the impaired biliary phospholipid excretion. What was happening is there is MDR3 deficiency, which is caused by this ABCB4 gene variation. It is a cholesteric syndrome in which there is impairment in the biliary phospholipid excretion. It is associated with the symptomatic and recurring cholelithiasis. So there will be recurrent cholelithiasis. Patients may show intrahepatic lithiasis, sludge, or microlithiasis along the biliary tree. Obesity has assumed an increasingly important role as a risk factor for the cholesterol cholelithiasis in children, particularly in the adolescent females. Cholesterol gallstones are also found in children with disturbance of the enterohepatic circulation of bile acids, including the patient with the ileal disease and the bile acid malabsorption, such as those with the ileal resection, ileal Crohn's disease, and the cystic fibrosis. Fine, and the pigment stones can also occur in these patients. Cholesterol gallstone formation results from an excess of cholesterol in relation to the cholesterol carrying capacity of the micelles in bile. What is happening is, why is cholesterol gallstone formation occurs? Because of excess cholesterol in relation to cholesterol carrying capacity of the micelles. Right, the micelle formation, micelles that are formed, they cannot carry all the cholesterol. So this leads to cholesterol gallstone formation, supersaturation of the bile with the cholesterol leading to crystal and stone formation. What is happening is supersaturation of the bile with cholesterol. This leads to crystal and stone formation, could result from decreased bile acid or from an increased cholesterol concentration in the bile. Other initiating factors that may be important in the stone formation include gallbladder stasis. So gallbladder stasis also contribute to stone formation, or the presence of bile in the abnormal mucoproteins or bile pigments that may serve as a nidus for the cholesterol crystallization. Okay. Prolonged use of high-dose ceftriaxone, a third-generation cephalosporin, has been associated with the formation of calcium ceftriaxone salt precipitates. Oh, so the drug that was most commonly used, ceftriaxone, in IV setting, it also has been associated with formation of calcium ceftriaxone salt precipitates, that is biliary pseudolithiasis in the gallbladder. Biliary sludge or cholelithiasis can be detected in more than 40% of the children who are treated with the ceftriaxone for at least 10 days. Oh my god. So this cholelithiasis or the biliary sludge is detected in more than 40% of the children who have ceftriaxone for at least 10 days. In rare cases, children become jaundiced and develop abdominal pain. Precipitates usually resolve spontaneously within several months after the discontinuation of the drug. Okay. Now, acute or chronic cholecystitis is often associated with gallstones. Mostly they are associated with gallstones. The acute form may be precipitated by impaction of a stone in the cystic duct. Fine, there can be stone impaction in the cystic duct. Proliferation of the bacteria within the obstructed gallbladder lumen can contribute to the process and lead to biliary sepsis. What is happening? There can be proliferation of bacteria within this obstructed gallbladder lumen, which can contribute to biliary sepsis. Chronic calculous cholecystitis is more common. It can develop insidiously or follow several attacks of the acute cholecystitis. The gallbladder epithelium commonly becomes ulcerated and scarred. More than 50% of the patients with the gallstones have symptoms. Okay. And 18% present with the complication of the first indication of cholelithiasis, such as pancreatitis or cholelithiasis or acute calculous cholecystitis. Okay, so only 15%, 18% patients present with the complication of the first indication of cholelithiasis, such as we are talking about the complication of cholelithiasis like the pancreatitis, cholelithiasis or acute calculous cholecystitis. The most important clinical feature of the cholelithiasis is recurrent abdomen pain. This is the most important clinical feature, is what? Recurrent abdominal pain, which is often colicky and localized to the right upper quadrant. It is what? Colicky and localized to the right upper quadrant. An older child may have intolerance for fatty food. Acute cholecystitis is characterized by fever, pain in the right upper quadrant and often a palpable mass. Fine. So in acute cholecystitis, what is happening is fever, pain in the right upper quadrant and a palpable mass. Jaundice occurs more commonly in the children than adults. Pain may radiate, so jaundice can also be seen. Pain may radiate to the area just below the right scapula. Pain is radiating to where? Just below the right scapula. A plain X-ray of the abdomen may reveal opaque calculi, but radiolucent stones are not visualized. Accordingly, ultrasonography is the method of choice for the gallstone detection. What is the method of choice? That is ultrasonography. USG is the method of choice for gallstone detection. Hepatobiliary scintigraphy is a valuable adjunct in that failure to visualize the gallbladder provides evidence of the cholecystitis. Laboratory evaluation may reveal elevated aminotransferase levels, leukocytosis and mild hyperbilirubinemia. Marked elevation of the direct bilirubin alkaline phosphatase or the gamma glutamyl transpeptidase (GGT) level should prompt evaluation for the cholelithiasis. So what is written here? That on laboratory evaluation there can be elevated levels of aminotransferase or leukocytosis can be seen, and there can be mild hyperbilirubinemia. But if there are marked elevations in the direct bilirubin and alkaline phosphatase and the GGT levels, then we should evaluate for cholelithiasis. Okay. Patients with the cholecystitis and persistent fever or concern for obstruction should be hospitalized and started on antibiotics. So cholecystitis patients should be started on antibiotics who have persistent fever also. Cholecystectomy is curative. Laparoscopic cholecystectomy is routinely performed in symptomatic infants and children with the cholelithiasis. So laparoscopic cholecystectomy can be done in children with the cholelithiasis. Common bile duct stones are unusual in children, occurring in 2 to 6% cases with the cholelithiasis, often in association with the obstructive jaundice and pancreatitis. Rarely a common bile duct stone may appear after a successful cholecystectomy Operative cholangiography should be done at the time of surgery. However, to detect unsuspected common duct calculi, endoscopic retrograde cholangiography with extraction of the common duct stones is an option before laparoscopic cholecystectomy in older children and adolescents. Asymptomatic patients with the cholelithiasis pose a more difficult management problem. Studies in the adult indicate a lag time of more than a decade between initial formation of the gallstones and development of symptoms. So, what is written here is patients who are asymptomatic, no, with who has cholelithiasis, they are more difficult to manage. More difficult management problem, because studies in the adults indicate a lag time of more than a decade between the initial formation. So there is a very long lag time. In adult studies, it is shown that there is a very long lag time of more than a decade between the initial formation of the gallstone and development of symptoms. So spontaneous resolution of cholelithiasis has been reported in infants and children. There can be spontaneous resolution. However, if surgery is deferred for any patient, parents should be counseled about the signs and symptoms consistent with the cholecystitis or obstruction of the common bile duct by gallstones. In patients with the chronic hemolysis or ileal disease, cholecystectomy can be carried out at the same time as another surgical procedure. Because laparoscopic surgery can safely be performed in children with the sickle cell disease, and elective cholecystectomy is being done more frequently at the time of gallstone diagnosis before symptoms or complications develop. So in case associated with the liver disease, severe obesity or the cystic fibrosis, the surgical risk of cholecystectomy may be substantial, so the risk and benefit of the operation need to be carefully considered. Okay. Thank you. This was all about cholecystitis and cholelithiasis. There's a small topic written about the biliary dyskinesia. Let's read that too. Biliary dyskinesia is a motility disorder of the biliary tract that may cause biliary colic in children, often associated with nausea and fatty food intolerance, but the symptoms may overlap with the functional abdominal pain. So, what is written was it is basically a motility disorder. Okay. And often associated with what? Nausea and fatty food intolerance, but its symptoms may overlap with functional abdominal pain. There are no gallstones on imaging. Sphincter of Oddi dysfunction may be a variant that can present with the chronic abdominal pain and recurrent pancreatitis. The diagnosis is based on the cholecystokinin diisopropyl aminodiacetic acid scan or an ultrasound done with the fatty meal demonstrating a gallbladder ejection fraction of less than 35%. So this is how the diagnosis is made on a very different name scan or ultrasound done with fatty meal demonstrating that the gallbladder ejection fraction is less than 35%. Reproduction of pain on cholecystokinin administration may also be seen, as well as the absence of gallbladder filling on any otherwise normal ultrasound examination. So there is pain on the cholecystokinin administration, because then the gallbladder will contract. That's why. And although laparoscopic cholecystectomy is preferred for many patients with this disorder, short-term and long-term symptomatic improvement is highly variable. Thank you.